So, without delay, we will talk about AF screening in 2025. Who really benefits? I have no conflict of interest. So why AF screening matters? As you know, AF is the most common sustained arrhythmia, and it's a major growing public health problem. AF prevalence increases with age, especially in people over 80 years old. At the same time, lifetime risk of AF increases with increasing risk factor burden. Individuals with multiple risk factors have 30% lifetime risk. Even people with optimal, as you can see here, people with optimal risk factors have about 23% lifetime risk, meaning AF is common even in healthy adults. The hidden problem of AF is up to 1/3 of AF cases remain undiagnosed, making silent AF a major clinical gap. As a result, up to 50% of strokes occur in people with previously unknown AF, so that's those events that could be potentially prevented. Because AF increases stroke risk 5-fold, and that coagulation reduces that risk by about 2/3, identifying these hidden cases is important for effective stroke prevention. Most international guidelines support opportunistic screening in older adults, while systematic screening is advised mainly in those over 75 years old. In the US, it remains more cautious due to limited outcome-based evidence. What are screening strategies? AF screening intensity ranges from opportunistic single-time checks to continuous ECG monitoring. Opportunistic screening, very short recording time, but often detects persistent or high-burden AF, so it detects higher stroke risk patients. For systematic screening, which moderate recording times, it captures more paroxysmal AF. Regarding consumer-driven detection, the screening time is variable and it's user-dependent, so diagnostic yield remains uncertain. Finally, for continuous recording ECG, it's a very intensity screening time, and it detects low-burden brief AF episodes. So, high screening intensity rises AF detection rate, but the clinical significance of AF varies. Opportunistic screening evidence, large RCTs show that opportunistic screening does not significantly increase AF detection compared with modern routine care, as shown in the D2AF and Vital AF trials. But systematic screening, when we systematically screen targeted population, detection rates rises, clearly overperforming opportunistic strategies. And when we systematically do ECG-based screening of older adults and mainly those with cardiovascular risk factors, detection rate can rise up to 5.8%. Regarding implantable device systemic screening, when we using continuous recording, AF detection rate rises dramatically and reaches up to 35%, especially in high-risk patients. So, the more we can monitor, the more we can detect AF. Excuse me. As shown in stroke stop trial, systematic ECG screening in older detects significantly more AF, but offer modest clinical benefit, slightly significant, statistically significant. But intensive ELR-based screening did not reduce stroke. The loop trial used implantable loop recorders, maximize AF detection, tripling number of diagnosed AF cases. But and increased the use of oral anticoagulation, but it does not significantly reduce the stroke rate. So this highlights that more AF detection does not necessarily translate into better outcomes, showing the importance of selecting appropriate population and tools. Recently, NOAA AFNET and Atrasia trials, these trials which focused on subclinical device-detected AF, they suggest that anticoagulating very low burden AF may not confer many great benefit and may increase bleeding. So anticoagulation with edoxaban and apixaban reduces the risk of stroke in patients with device-detected atrial fibrillation but increases the risk of major bleeding. Recently, wearables have changed the public perception and making rhythm monitoring accessible to millions. They can detect regular rhythm with a very high accuracy. And most wearable detected AF represents subclinical AF in younger users with low risk of stroke, so they don't need anticoagulation, and that limiting the clinical benefit of widespread screening. When combined with confirmatory ECGs, wearables achieve high specificity and positive predictive value. And wearables are therefore more suitable for monitoring than for mass screening, allowing us to screen smarter but not harder. Next generation tools aims to refine screening and refining the target population through biomarkers and prediction algorithms which greatly improve the effectiveness and the efficiency of AF screening. So, what are AF screening benefits? The primary benefit is when we are detecting previously unrecognized AF, we enable timely oral anticoagulation to prevent stroke. So this is the major benefit of AF screening. And we don't forget that screening is not harmless. And false positive patients leads to unnecessary anticoagulate them, and the major risk is the bleeding due to this unnecessary anticoagulation. There are also increased healthcare costs, overdiagnosis of low AF burden, and patient anxiety and repeated follow-up visits. Let's talk money and the cost effectiveness of AF screening. Economic modeling strongly supports that systematic screening in older adults is highly cost-effective, and the extended monitoring is economically favorable and clinically impactful. So, AF screening fits on almost all WHO principles for screening, so it's important to implement a screening strategy, but who really benefits in 2025? Here the question is no longer whether we can detect AF or not. Obviously, we can detect it and we can detect it effectively. But the real question is, should we treat every AF episode we detected? We have to take in mind that our goal is not to find the most AF, but to prevent the most strokes with the least harm. So, the ideal group target is patients over 75 years old, or people over 65 but with risk factors of stroke, such as hypertension, heart failure, diabetes, and vascular diseases. We should also screen patients with elevated NT-proBNP and those who have high predicted risk with algorithms like FIND-AF, and patients, especially patients who are not previously anticoagulated, to initiate this anticoagulation, and those able to comply with screening and treatment. When we implement a screening strategy, we have to implement also the AF care strategy pathway. So when any AF is detected, the patient should follow immediately the AF care pathway. And with any AF screening strategy, the risk modification should always be done in every patient, identified with risk factors. So to conclude, AF is common, dangerous, and often silent. Opportunistic screening has limited impact. Systematic targeted screening in older high-risk adults offer the best yield. And prediction tools and biomarkers will shape the future screening. Screening must be balanced with risks, costs, and patient-centered outcomes. And don't forget, premium non-nut cherry, first do no harm. And I would like to ask you to save dates to join us the 1st of March 2026 to the Global Arrhythmia Awareness Day, Pulse Day, to make the awareness of about arrhythmia in people, and the 1st or 2nd May for Tunisian meeting of arrhythmia. And thank you for your attention.
Thank you very much, Emna. I think the discussion will be at the end of the
Thank you.
presentation, and the next presentation will be. Okay. Thank you. The discussion will be at the end of all the presentation. So the next presentation will be by Sana Wali from Tunisia. Is there still room for rate control?
Thank you very much. It's my great pleasure to be associated to this ERA session. During this 15 minutes, I will try to respond to this question. Is there still room for rate control in 2025? This topic cannot be separated from socioeconomic factors. In which healthcare system will this issue be addressed? And what is the stage of AF that we will manage? We know that we have different stages with varying degrees of complexity and physiopathologic mechanism. We know that AF is a progressive disease involving initially the pulmonary veins, then more complex mechanism with diseased substrate and multiple oriented foci that will be involved. So we have different patient pathway. Also, and similar to heart failure, atrial fibrillation is classified in 2 different stages, ranging from subclinical AF, paroxysmal, persistent, permanent, and we will try to answer to the question I was asked through 3 cases based on the clinical presentation from the far right to the far left. So my first patient will be it's a young patient, beautiful patient, suffered from AF since 2015, and he has a huge left atrium. He suffered from rheumatic mitral stenosis, and he had 2 percutaneous mitral balloon valvuloplasty. And I will ask the audience, what will be your approach in this case? I think that in this case, the approach is easy because we don't have any choice. We have only the rate control to strategy for this patient. So no chance, no hope for this patient. My second case is from the left, de l'extrême gauche, 16 years man, suffered from palpitation for 7 hours only. First diagnosis of AF in the emergency room, no prior history. He was stable but uncomfortable. And my question is, what is your strategy in this patient? What will you do? Do you propose to this patient a rate control followed by cardioversion, or immediate cardioversion, or rate control followed by wait and see, or you observe only your patient? The EC guidelines states that in patients with newly diagnosed AF, rate control should always be initiated first, unless there is a hemodynamic instability. Afterward, cardioversion is indicated if AF persists. So a wait-and-see approach for spontaneous conversion to sinus rhythm within 48 hours of AF onset should be considered in patients without hemodynamic compromise as an alternative to immediate cardioversion. So in this case, and this results from a study, a trial, comparing 2 strategies, In fact, among patients presenting to the emergency department with recent onset symptomatic atrial fibrillation, a wait-and-see approach was non-inferior to early cardioversion in achieving sinus rhythm at 4 weeks. So, in this patient, we have the choice. We can choose rate control followed by cardioversion or rate control followed by wait-and-see. We continue the presentation with this patient, and this patient will express 3 paroxysmal recurrences in the past 6 months. Of course, as usual, we start by a rate approach, and after that, we propose to our patient rhythm control after a shared decision-making process. Conceptually, it seems only logical that maintaining sinus rhythm in patients with atrial fibrillation will permit them to live longer and better. However, this has proved to be a difficult task, and rhythm control has not always led to benefit in patient-reported outcomes. In this meta-analysis involving 18 studies with a total of 17,000 patients, this study showed a real benefit of rhythm control with reduction of cardiovascular death, stroke, and heart failure. And this result, this benefit of rhythm control, has primarily driven by the more recent studies, including patients treated early or patients with heart failure. And we see that all the benefit come from these 3 studies, very contemporary randomized studies. If we see all the guidelines through this last decades, there is a growing body of literature supporting early rhythm control, especially by catheter ablation compared with antiarrhythmic drug therapy. I go then to a case, for me, it's a gray zone. It's a 72-year-old retired ophthalmologist, a colleague, suffered from hypertension with a persistent AF for more than 2 years. He had a good left ventricular ejection fraction preserved with a dilated left atrium. He benefited from catheter ablation in 2022 and 2024, and he had recurrences despite amiodarone. And when he returned to sinus rhythm, he expressed an improvement. I will ask you, what will be your approach in this patient? Please, what we will do? In my country, maybe I will say to the patient, this is my maximum to treat you. In another country, in Toulouse or in Paris or in United Kingdom, this patient will have another procedure maybe. So the question remains whether a relapse of AF indicates that the window of the rhythm control has closed, or whether he should focus all our efforts in achieving sinus rhythm at all costs. In fact, atrial fibrillation is not a sporadic situation, it's an endemic situation affecting more than 33 million people with an incidence of 1.5 million in United Kingdom. The number we know that atrial fibrillation will double in 2016. And if there is in one of the audience will suffer, 1 of 5 from the audience will suffer one day from atrial fibrillation. And we know that long-standing persistent atrial fibrillation is the largest AF patient population. And if not properly treated, atrial fibrillation can become worse. The ESC guidelines say that we have to use rate control drug as initial therapy, and we consider rhythm control in all suitable patients. Who are the suitable patients? Are they the beautiful woman, the handsome man? Who is the good, who's the bad, who's the ugly? What's the cutoff of left atrium where we stop, we say we can't perform another procedure? Are they heart failure patient? What are the morbidity? So if we look to the definition of the permanent atrial fibrillation, this definition of permanent AF is the same here in Tunisia or in Europe. AF for which no further attempts at restoration of sinus rhythm are planned after a shared decision between the patient and physician. In my country, maybe I perform 1 procedure, 2 procedures at least, but no more. And maybe in the future decades in Europe, this definition will disappear because they treat correctly comorbidities and they treat correctly early the atrial fibrillation. And if we see the best trial in the world treating with catheter ablation the persistent AF, the success rate of catheter ablation for persistent AF is only around 40%. This is true even when we use lines, we use low voltage ablation, dispersion ablation, and this maybe is this low success rate can be explained by the non-transmurality of lesion. And if we ask Dr. Serge Bovida or Dr. Pascal Defay, he will use in this patient new energies, he will combine energies to have transmurality. He will send his patient to the cardiac surgeon to have an hybrid ablation. This in my country is not possible. So we don't have the same socioeconomic condition. We have more difficult patient because we treat this patient. We don't treat early our patient. We have uncontrolled hypertension. We don't have the same procedure factors. When we have 1 catheter for 1 patient, we don't have in all patients steerable sheath. We don't have for all patients the PFA. So we don't have any condition. We know that the success of catheter ablation depends on all these factors. So despite all the enthusiasm for and fast implementation of a default early rhythm control in all patients, only a small minority of patients with AF are currently treated with rhythm control in my country. We have long waiting list for AF ablation, making this early rhythm control in most countries difficult to achieve. And I will finish by that rate control is a primary treatment approach for management atrial fibrillation. We try to push to have an early rhythm management. Decision must be made case by case after an informed decision-making process with the patient. But sorry, socioeconomic condition is one of limits in my country. If I forget the socioeconomic condition, I will say for diagnosed AF, rate control strategy is the first choice. Paroxysmal and persistent AF, I will try to have a rhythm control strategy. For permanent AF, rate control is the choice because we don't have any choice. And ne jetez pas facilement l'éponge. Maybe in the future, we can detect earlier the atrial fibrillation. We can manage the comorbidity. Maybe with artificial intelligence during ablation, we have better results. Maybe if we implement our cath lab with new energies, this can help us to control this arrhythmia. And thank you very much for your attention.
Thank you, Professor Sanaweli, for your excellent presentation. And now we will have a debate on ablation of atrial fibrillation and focus on the kind of special energies. And I invite with the great pleasure Professor Pascal Defay to talk us about her opinion on the technique of one shot.
Okay. Dear friends, I'm not Serge Boveda, and I will do this presentation on behalf of Serge. Serge apologizes for not being there due to an unavoidable scheduling conflict. But I'm very, you said that I'm very happy to be there in the Tunisian meeting of cardiology. I'm very impressed concerning the dynamic of your community, and you know that I'm very happy to be there in your country. It's a country that I know very well. So my presentation will be about one-shot. It's a debate, and I will defend one-shot ablation. And first of all, I would say that the first one-shot technique is cryoablation. And I have, during long term, advocated that this technique. I have defended this technique during numerous years. And you know that cryoballoon ablation in this study is non-inferior to RF with respect to efficacy for the treatment of patients with drug-refractory paroxysmal atrial fibrillation. And there is no significant difference between the two methods, between cryoballoon and RF, multipoint. Now is the era of PFA, of pulsed field ablation, and you know that since this study, advanced study, PFA is non-inferior to point-per-point ablation. You can see the curve of survival without recurrence of AF. And if you look to the serious and non-serious adverse events, there is no significant difference also. And among patients with paroxysmal AF, PFA is non-inferior to conventional thermal ablation. And now, moreover, we have a study showing that PFA is at least non-inferior, even superior, comparing to cryoballoon ablation. And probably in the future, PFA in what we can call one-shot ablation is not true a one-shot ablation, but very close to one-shot ablation. Will win the debate, and you know this single-shot champion, the one-for-one randomization between PFA with Farapulse and cryoablation, and the follow-up is performed with a reveal link, and you know the survival curve without recurrence. We have a non-inferiority and even a superiority, a calculation of superiority between pulsed field ablation, PFA, and cryoballoon. And the secondary endpoint with ILR concern the atrial arrhythmia burden, and you can see that at D90 and at 1 year, the burden with PFA is significantly inferior comparing to cryoballoon. And very recently, the result of beta-F is not published for the moment, have been presented at the American Heart meeting, comparing single-shot PFA and point-per-point with RF. It was a superiority study, but in fact, with the primary endpoint, the superiority was not obtained, and only the non-inferiority. And the primary endpoint includes absence of atrial arrhythmia recurrence more than 30 seconds, no class 1 or 3 antiarrhythmic drug resumption, absence of radioablation in the 12 months. But when you look to the adverse events between PFA and ERF and radiofrequency, concerning the serious adverse events, you can see we have just 1 with PFA and 14 with multi-point RF, and a lot, 12 PV stenosis, more than 50%. So the PV stenosis is not finished with RF, even in very experienced centers. And when we compare the safety endpoint, 11 with RF with multi-point and only 7 with PFN, you can see that there are some severe pulmonary stenosis in expert centers, more tamponade, 2 tamponades, 0 in the group PFA, at more prolonged hospitalization day, 9 versus 6. So in conclusion of BTAF, this randomized study performed in patients with drug-resistant paroxysmal AF demonstrate excellent efficacy of single-shot PFA compared to RF using the closed protocol with no superiority, but it's a non-inferiority. However, PFA was faster with fewer adverse events, mostly because of PV stenosis in RFA in high-volume X-per center. It's important. We can say that young PFA is already as effective as old RF technology refined over 30 years. And we have also the result of the European Uporia registry with no difference in chronic effectiveness based on operator years of experience. There is no difference with PFA for operator with less than 2 years, 2 to 5 years of experience, and 5 years, exactly the same reproducibility concerning the outcome based on operator experience. Here, you can see the easiness of perform the one-shot PFA ablation with this catheter, the FARA+ catheter. Remember that the duration of PFA application is around 10 seconds, so it's very fast to perform isolation of the PV. And another advantage that you can perform also extra PV lesion. On the left, an example of ablation of the posterior wall of the left atrium, and on the right side, an example of the mitral isthmus performed with PFA. Concerning the true one-shot, the cryo, you can see here the target zone of the cryo balloon. It's a circumferential PVI with big balloon, and we can confirm the example of the left atrium with a mapping system, the CARTO after cryo. So the isolation of the trunk is absolutely complete and efficient. Here you can see also another image. It's a fusion of the CT scan with a workstation of GE from the Clinic Pasteur. And so you can see the Achieve catheter. The Achieve loop catheter placed very close to the balloon, and the placement of the Achieve catheter is a key to allow real-time assessment of PV isolation. And you can see also, you can confirm the entrance block with cryoballoon directly during isolation, very quick after the beginning of cryo application. And Serge has published the concepts of the entrance block and the exit block. When you pace the inside the pulmonary vein with the Achieve, you can confirm that there is an exit block with cryoablation. And another advantage of cryoablation is that it's very easy it's very reproducible. And when we compare, this study has been performed in the center of Toulouse, in Grenoble, in Bruxelles, and Rouen, and London. And we have compared in all centers the inter-observator reproducibility between one shot and point by point. You have on the left one shot with cryoballoon, and on the right RF multi-point. And you can see that the cryoballoon seems to be less operator-dependent and more reproducible than RF in the setting of paroxysmal AF ablation. And look to the results. The follow-up is better. The blue line is a cryoballoon, is better with cryoballoon compared to point per point. And concerning the predictor of freedom from AF in this study, we have found the experience of operator, more than 100 AF by operator. Cryoballoon the use of cryoballoon is also a predictor of freedom compared to point-by-point RF. And when we look to the recommendation for catheter ablation, the last European recommendation for ablation of AF, we have a recommendation for first-line rhythm control, particularly for class 1, is now recommended as first-line therapy in class 1 for paroxysmal AF. And in fact, these recommendations are particularly based on studies with one-shot technique and particularly concerning cryo. You can see here the early AF study, but there are also other studies with cryo as an initial treatment of atrial fibrillation. And you can see that cryoablation is superior to antiarrhythmic drugs. The p-value is extremely significant concerning the freedom for recurrence of atrial arrhythmia, and this population had revealed, and you can see that the burden is very low after cryoablation. And now it's an era of PFA, and why we believe that now the single shot with PFA is safer than point-by-point is because the energy is relatively specific of the atrium, the myocardium of the atria, compared to the nerve, compared to the smooth muscle. It's not perfect, you know the complication like hemolysis, but concerning the risk, there is no risk of phrenic palsy, for example, and no risk of atrioesophageal fistula or of stenosis. And in fact, when we look to the tool for AF ablation, here is a consensus document of ERA. You have the two one-shot technique, cryoablation and pulsed field ablation, presented in parallel to the historic point-by-point RF. So, as a take-home message, we can say that PFA, cryo, the two one-shot technique are efficient, both are safe, both are fast, both seem reproducible. So it's a shorter learning curve for PFA for balloon user compared to multi-point RF. We have more than 15 years of evidence with cryo for PV isolation. It's probably more cost effectiveness for some country compared to PFA. Both are very reproducible, so probably the difference may be for extra PV lesion. You cannot perform extra PV lesion easily with cryo. We can easily perform extra PV lesion with PFA. Why dual energy catheter for persistent AF? It's a debate. You know that now we have the Afera system with dual energy. Personally, I have no experience of this catheter. Serge has experience of the Afera catheter. And for me, it's a beginning, and for Serge, of a new paradigm. Thank you. Thank you very much.
Thank you very much, Pascal, for this nice presentation. And next, we will hear about point-by-point ablation from Dr. Rafiq Chatawi, head of the electrophysiology unit at Les Berges du Lac Clinic. Dr. Chatawi, you have the stage.
Thank you, Sonia. I am pleased to be here in this joint session with Tunisian Society of Cardiology and ERA. And my task is to speak about point-by-point strategy. I will show you in my presentation that these two, I don't have any conflict of interest, these two strategies are still complementary, and I think that there is still a room for point-by-point ablation in this indication. Comparing one shot to point-by-point is comparing mini explosion to sniper strategy, because when we do point-by-point, we see what we are doing. We see the signal, and we know the harm that we have done to the signal. But with one shot, we don't see anything. We see the result after after the application and not in the meantime when we applicate the energy. So with point by point, we can see fragmented potential. And when we do the application, we can see what we are doing to the signal. And in real life, it's helpful for us as electrophysiologists. And we can see in the meantime, when we isolate the vein, we can see easily the disappearance of the pulmonary potential, and we can confirm that the vein is disconnected. We can even see continuous activity in the vein with an exit block created by the line that we performed on the antrum of the pulmonary veins. The study showed non-inferiority of one shot, and Pascal showed us in some study, these are another studies, that showed that in the era of cryoablation, there is no study demonstrated superiority of one shot versus point-by-point ablation. And in the era of cryoablation, we met non-inferiority criteria. And the Ice and Fire study, we met the criteria of non-inferiority of cryoballoon ablation versus radiofrequency ablation with the same amount of complication. There are different complications, but let's say we have no more complication with radiofrequency ablation in comparison with cryo. This study is recent, and the study compared the three energy, and the study didn't show any superiority of one on other studies. So when we speak about pulse field ablation, cryo, and radiofrequency ablation, there is no difference. And even when we see the complication, there is no more complication with radiofrequency ablation point by point when we compare it with one-shot strategy. This is the study showed by Pascal, and it shows that the pulse field ablation with a strategy of one shot in the vein is not superior. Let's say radiofrequency ablation, pulse field ablation is not inferior to radiofrequency ablation because the study is not dedicated to show superiority. Radiofrequency ablation evolved because catheter evolved, and we have now catheter that can give us a lot of information to have more safety with the point-by-point procedure. So we moved from the irrigated tip catheter that preserve and that prevent thromboembolic event when we work in the left atrium with a very good result in 2000, from 2002 to 2020 to 2011. We showed with the irrigated tip catheter with point-by-point ablation that we are superior to drug therapy with follow-up of 1 to 4 years. This study published by the group of Pierre Jaïs in Bordeaux showed that with the follow-up of 4 years, the point-by-point strategy is superior to drug therapy. why we focus on pulmonary vein, because we did a prospective study, STAR-IF, that showed that if we do not more than pulmonary vein isolation, we don't have benefit. We don't have benefit with the strategy of ablation of fragmented potential, and we don't have benefit with the strategy of lines. So we still stick to the isolation of pulmonary vein with both strategy. In 2012, it was the era of the contact force sensing, and it was another revolution in the point-by-point ablation, because we now know how much force we are applying to the left atrial wall, and in the beginning of the experience, we showed that with the contact force, we save time. So the strategy is the ablation time is less important, and we are more efficient, because we know if we do transporter lesion or not. And this concept evaluated with time. The study show very well that if we use contact mapping and if we compare contact mapping to conventional ablation, contact mapping have a better result, significantly better result. And with contact mapping, we have now other indicator like FTI, the force time integral, and the AI, the ablation index. And if we meet the ablation index to the drop of impedance, we can really know how deep is the lesion in the atrium wall, and if you are efficient or not. So we have a lot of information with point-by-point ablation that can help us to know if the lesion is efficient or not. And another application to these index is to apply the index in the region where the wall is thick, to apply more energy, and to apply less energy in the part of the wall where the wall is thin, in particular the posterior wall and the proximity of posterior wall with the esophagus. So a study have been performed with the ablation index and with point-by-point ablation very close, and demonstrated that we are, with this strategy and with this workflow, we are superior to conventional strategy and significantly superior to conventional strategy. We speak about radiofrequency ablation. And if we put a proper workflow, we will see that intra-operator, we don't have an inter-operator difference if the workflow is properly followed by the operator. This is the close-guided PVI study that showed that we are really efficient if we stick to the ablation index in the anterior wall, posterior wall, and if we do very close point-by-point lesions. This study showed that if we do tomography before ablation, so we can have an idea about on the thickness of the left atrial wall, so we can program the energies that we will apply and the force that will apply on the left atrium wall to predict the difficulty of the procedure and to obtain better result when we apply the right energy in the right place. The time of the procedures in the recent study have been shortened by the use of the high power short duration strategy. So high power short duration, we can speak about 90 watt for 5 seconds, but we can speak as well about 50 watt for 10 seconds with special catheters. And we demonstrate that with high power short duration, we have not only a shortness of the procedure time, but you have more stability and more reliability on the result. And with high power short duration, because it's short duration, so the heat doesn't go far through the posterior wall if we apply it properly. And when we speak about high power short duration, we demonstrated that there is no difference in the results between all the strategy of high power short duration, but the benefit is here, the time of the procedure shortened by 30%. So we can do now point-by-point ablation in around 1 hour and 15 minutes. This is the Q dot, the fast and furious study done with the Q dot catheter that demonstrate that we save time, we save drilling time, we save time, and the mean procedure time is 1 hour. One word on the Sphera catheter. The Sphera catheter is now a catheter that do both radiofrequency ablation and PFA ablation, because the point-by-point is not a matter of only radiofrequency ablation, but it's a matter of PFA ablation as well. And the Sphera catheter is used now for redo cases of one shot, because with redo cases, so we know where the connection is, and we can go straight away to do the ablation, and we can save time. And some studies now are ongoing on the efficacy of Sphera catheter in this indication. So in conclusion, the superiority of one-shot strategy is not yet demonstrated. The point-by-point strategy is a pure electrophysiologic approach, in my point of view, in a way that we see that what we burn, and we can easily check the line and check the line when we do a line, so we can check easily if the line is blocked or not. In redo cases, in redo one-shot cases, point-by-point approach remains the gold standard. The ablation index approach with closed point-by-point ablation is still promising. High power short duration ablation saves more much time than conventional ablation. And point-by-point RF PFA with Sphera now seems to be promising, especially for redo cases. Thank you very much for your attention.
Thank you, Rafiq, for this very nice presentation. And now I will invite my friend, Professor Pure Ferner from Austria, President of European Heart Rhythm Association, to share with us about the future, the next, of the management of atrial fibrillation. You have the floor.
Merci beaucoup. Thank you. I'm very happy that I'm here. Thanks, Professor Benhammer. Dear colleagues, ladies and gentlemen, it's a pleasure to give this presentation, and it's a pleasure to see so many women here in arrhythmology. That's really, really something. I appreciate it a lot. I have to talk faster now. So that's my topic. What's next for AF management? These are my conflicts of interest. So what we published in 2024 was an expert consensus statement on catheter and surgical ablation of atrial fibrillation, together with our sister societies, so Heart Rhythm, Asian Pacific, Latin America. And what we still have as the most important thing here is this one. Electrical isolation of the PVs is required during all of AF ablation procedures. So please do not forget about that. That's the most important thing we have to do. And if we achieve electrical isolation, it requires at a minimum assessment and demonstration of entrance block into the pulmonary veins. So that's what we have. How can I go back? Now go to next. If we do something more than that in persistent atrial fibrillation, for example, then if we have linear ablations, then mapping and pacing maneuvers are required to document conduction block. So whenever you do more than the veins, and the veins have to be isolated, whenever you do more, you have to show that there is conduction block. That's it. That's the most important thing. Everything else is of minor importance. The rest is we don't know too much what we should do in persistent atrial fibrillation. And so this will now be the core of my presentation. What do we know at the moment? We know that recurrent paroxysmal atrial fibrillation should be ablated. It's better to ablate than to give drugs. Indications. We know that if patients have a systolic dysfunction, especially if it's presumed to be by AF-mediated cardiomyopathy, ablate early. So the ones who have an early comer atrial fibrillation in heart failure, ablate atrial fibrillation. If atrial fibrillation comes late in the course of heart failure, select. In some patients, it's wise to exclude atrial thrombi. We don't do it that often because many of our patients are, of course, anticoagulated. And so if they're anticoagulated, they normally are not undergoing any TEE. They have some CT scanning before in a lot of patients where we want to see the veins, but otherwise we don't do more. However, if they are at high risk, hypertrophic cardiomyopathy, amyloidosis, then if you do ablation, that's a hard job, of course, to know. If you have an hypertrophic cardiomyopathy patient, it might be even something with surgical ablation, then you should look for thrombi. If you have vascular access, routine ultrasound is important. It makes life easier. I have now been doing ablations for 35 years, and I have started ultrasound punctures 5 years ago, and I would never give it up again, never, although I think I can do it quite well without. On the ablation strategies, we know that PVI remains the cornerstone. Everything else is under debate, although we have some data, myself and my group, published in the New England on ERASE, that we can also ablate low voltage areas in some patients. The workflow of atrial ablation. In surgical AF ablations, please exclude the left atrial appendage, and if you work with your surgeon colleagues, the biatrial Cox maze or a minimum of PVI plus posterior wall isolation during concomitant open AF surgery is required. Burden becomes more and more interesting. We have seen so many slides here where you see this 70% of success when you use 30 seconds as a success criterion. I think it's not the best way. I think we are doing something wrong here. We should measure burden, and maybe in the future we can measure it by some handheld devices, some watches and risk tools in order to see that we are reducing effectively the burden. In many of the patients where we have 70% success rates, they have a reduction of 99% of atrial fibrillation. If you look at for example, neurologist or some other general medicine doctor whom you approach and say, I have a lot of pain, and he will tell you, you will have 99% reduction of pain, then you would say, this is a fabulous doctor. It's fabulous. We say, no, we're not fabulous. We have 70% reduction because there was one recurrence of more than 30 seconds. I think it's not good that we do this. So we should go over to burden. We should look about the blanking period that has now been reduced from 3 months to 2 months. And we have to look about anticoagulation and think about anticoagulation. You have seen that there are some studies now out that say the risk after ablation of getting a stroke in a successful ablation is very, very, very low. So I think we will have patients in the future where we do not need any anticoagulation at all, nothing. And of course, same-day discharge is also becoming more and more important. So that's what we know. However, what we don't know is also a lot. We don't know about risk factor management. How will it be broadly implemented successfully to change the style, the lifestyle of a patient, to change behavioral issues in a human being is very, very difficult. Very difficult. So whether we are successful in recommending and then having an outcome that is better is unclear. We recommend, but we have not shown in a randomized controlled trial that the outcome will be better if you lose weight, if you have more adherence to these care recommendations that we have in the new guidelines. So do we have drugs for AF prevention? What about the GLP-1 agonists? Are they revolutionizing also AF? Could be. What about AI in the future? There have been some studies out on artificial intelligence to look at the signal and then interpret the signals as being crucial for this persistent atrial fibrillation or not crucial. This is very, very interesting, but we are not there. How about first-line ablation in persistent? We don't know. How about ablation to improve the outcome of the patients, especially if you use PFA? I only can tell you, I do not do routine posterior wall isolation in persistent atrial fibrillation. I do not do that because I think we don't have any evidence that this is beneficial. We need much more evidence. We're doing a lot of things where we don't know what to do. The mechanisms of persistent atrial fibrillations are unclear. The strategies for more than PVI are unclear. Follow-up, how can we do a better follow-up in the future than just by symptoms or by 24-hour long-term recordings? I think we have to have these PPGs on our arms to measure the burden supported by artificial intelligence. I think we need that badly in the future. And of course, oral anticoagulation. OCEAN trial was presented just 2 weeks ago, showing that Xarelto, rivaroxaban, after 1 year is not necessary in patients with a good outcome after ablation because the stroke rate is so low. So that's the unknowns, and we need a lot of things to think on, and that's why my topic is era scientific documents. Yeah, we are having some documents in the future. There will be a very nice one, this one here, with beautiful illustrations, I can tell you. I can't show it because it's all under embargo. This is the management of patients with atrial tachycardias. We will provide you with fully new sets of definitions what an atrial tachycardia is, and it will be a super paper presented during next era in Paris on this atrial tachycardia stuff. The next thing, pulsed field ablation. I'm now writing with a Swiss colleague and lots of other colleagues around the world on this PFA for interventional treatment. This will also be published next year on the status of PFA. Same-day discharge will be a paper. and of course a lot of other papers in other areas of arrhythmology. In 2025, we also had the practical guide of antiarrhythmic therapy. The colleague was referring to drugs. We still need a lot of drugs, and especially the young colleagues are not very strong in prescribing drugs because they have forgotten about how to treat atrial fibrillation in sinus rhythm maintenance, in rhythm control with drugs. They don't do it. And if they do it, they don't look at the things that are necessary in order to avoid complications. And we have a very nice clinical consensus statement on the practical guide on vascular access. And I really recommend this paper. It's already been published. So we have a lot of documents that we have on these issues that are so important now, and a lot of documents on issues that we don't know how to really tackle. So my second hat is the ERA president. So ERA is your community for career development, for education, science, and the ERA Congress. And let me do some advertising on that. We have now more than, in 2024, we had 4,000 members. Now we have 5,000 members around the world. So we are quite a big community now. And I think we are here for you. We are here for you. We want to do things better in the future. These are my colleagues. As you can see, I'm the president. This is José Luis, past president from Spain. Professor Marino, Professor Borre will be next president. Emma is treasurer, and Serge Poveda, who couldn't make it today, is secretary at the moment. And what we have a very extraordinary educational pathway to offer, with a level 1 with on-site, online, introduction to arrhythmology with a level 2 with on-site courses on electrophysiology and device implantation, so courses on AFib, VT, examination prep courses, online courses on SVT, we have pacing courses, and we have advanced CIED courses. And then we have the exams in both, and after you have passed the exam, you can apply for level 3, so to become a leader in electrophysiology. I hope that many women will apply from Tunisia for this level 3. So for certification, in this year, in the year 25, we have started a French exam in CIED. And next year we will have, hopefully, both the French exam in CIED, but also in EP, so that the language barrier is no longer a barrier to prove your competency. So join ERA. It supports your professional developments on a lot of discounts, as you can see here, Congress, on-demand resources, exams, opportunity to become a fellow of ERA, etc., etc. And so there is my last slide, and I'm still in time, thank you. And that is, come and join us for next year at ERA 2026 in Paris. Thank you.
Thank you very much. We have to close this session. It was a very relevant session. I would like to thank all speakers and audience, moderates, and I invite you to stay in the room for the symposium of Terra Laboratoire.